Welcome back, guys. Now we'll discuss about the small bowel obstruction due to fibrotic stricture. This topic I have kept separately because most common cause of bowel obstruction is because of adhesions post-operative. But whenever there is fibrotic stricture, the question goes like this. 34-year-old male patient who has got a background history of Crohn's disease now presenting with recurrent vomiting. You will have to think of formation of the strictures. Very important. Whenever there is formation of the stricture, the patient will have vomiting, which is bilious. The patient will have abdominal pain, and on examination it is a small bowel obstruction, so you will find hyperdynamic bowel sounds. Please, the treatment is immediate surgical resection of the suture. Very important. Next, we talk about the paralytic ileus. It is basically because of the abdominal surgery, hypokalemia, opioids. So you'll have to treat those. And remember, whenever there is ileus, you will not find the differentiation between the bowel loops because there is no transition point and there will be gas that is filled off loops. Remember, the management is bowel rest and you will also have to treat the underlying conditions. Next, we talk about management of perforation of hollow organ. Whenever there is hollow organ perforation, please do an upright X-ray. If you do air under the diaphragm, it is basically suggestive of air under it is basically suggestive of perforation of a hollow organ. The most common organ being the rupture of a not rupture but peptic ulcer disease complication or perforation of a duodenal ulcer. Please, whenever there is no air under the diaphragm and you still think that this patient is got a suspicion of perforated hollow organ, you will have to do a CT scan of the abdomen with the contrast. That is what I want you to remember. Next, we talk about Oglieve syndrome. Oglieve syndrome, my favorite syndrome, it is the pseudocolonic obstruction. Whenever there is pseudocolonic obstruction, please do remember that there is colonic dilation, usually in the proximal colon. In Oglieve syndrome, it is the normal haustral markings that are present, but small bowel is not involved. It is the large bowel that is involved. When you do a CT scan, you will find colonic dilation, but there will not be any stricture. There will not be any physical obstruction or anatomical obstruction. When you find Oglieve syndrome, you will have to make sure that the patient is not using anything by mouth. That is, nil per oral must be done. And next one is colonic decompression by placing an NG tube is the first step in the management. Sometimes you can also place a rectal tube in order to allow the decompression to happen. If the patient is not responding to NG tube and the rectal tube, please do remember neostigmine can be used as a drug, but it can be used only after 48 hours of not improvement of the symptoms, please. Very important. Next, I want to talk about gastric outlet obstruction. Remember, you will find a 60-year-old Chinese descent, Indian descent, Asian descent presenting with epigastric mass. Think of gastric cancer. The most common cause of gastric outlet obstruction is gastric malignancy. Sometimes there can also be pancreatic adenocarcinoma or long history of gastric ulcer, which is changing into gastric malignancy and then it is causing gastric outlet obstruction. Patient usually presents with early satiety because abdominal distension is distended. Basically, gastric is distended after having some amount of food. So early satiety will be present. There can be pain. There can be vomiting as well. Whenever you do an examination, it is usually an abdominal succussion splash that is usually heard on abdominal examination, please. That is how you will have to think of gastric outlet obstruction, and the treatment of gastric outlet obstruction is treat the malignancy. Next, we talk about refeeding syndrome. Whenever you think of refeeding syndrome, I want you to understand this is characterized by hypophosphatemia because most of the phosphate is diverted to formation of the ATP. Whenever patient is admitted to ITU, not eating, very critically ill, what happens when you suddenly introduce patient with the feed? Whenever there is patient with the feed, what happens is the insulin increases. Whenever there is insulin that is increased, what happens is the electrolytes are taken into the cells. What electrolytes are taken? It is the hypokalemia, it is the potassium, magnesium, it is the phosphate that is usually taken in. So patient usually presents with hypokalemia, hypophosphatemia, and hypomagnesemia. And this phosphate, whenever it is taken in, it is usually used in the formation of ATP and 2,3-diphosphoglycerate. This is important for step one. That is why you will find low phosphate and low potassium. Patient presenting with hypophosphatemia and hypokalemia after feeding, think of refeeding syndrome, please. What is the management? Correct the electrolyte abnormalities, and you will have to make sure that there is close monitoring of these electrolytes. The patient, in the question, the patient can present with the weakness, the patient can present with arrhythmias, and the patient can also present with the altered mental status. That is when you will have to think of refeeding syndrome, please. Next, we talk about appendicitis. We will call it a day for today, and then we'll talk about appendicitis tomorrow. There are 50 more topics to be done, and we can complete gastrointestinal surgery tomorrow. Thank you guys for joining. I'll see you in the next session.